Hello people, in this video let us look at NYHA classification of heart disease. There are many types of NYHA classification. In this one we are looking at the heart disease. Okay, so this is based on symptoms. So you can see that green is you have grade 1, 2, 3 and 4. Okay, the first one is grade 1 where it is uncompromised. There is no limitation to ordinary physical activity. Okay, so that is uncompromised. See, the mnemonic here is USMS, uncompromised, slightly compromised, markedly compromised, severely compromised. Okay, USMS. So what is the first one? Uncompromised. There's no limitation to ordinary physical activity. They have shown here, this man is running, you can see. Okay, then coming to the second, that is grade 2. Grade 2 is what, guys? That is slightly compromised. Okay, so ordinary physical activity causes discomfort. Ordinary physical activity causes discomfort. Okay, that is slightly compromised, grade 2. Now let us move to grade 3. Grade 3 is markedly compromised. He cannot even do ordinary activity. So less than ordinary activity causes discomfort. Okay, so that is markedly compromised, grade 3. Grade 3, markedly compromised, less than ordinary activity causes discomfort. Okay, grade 4. Now we are moving to grade 4. Grade 4 is severely compromised, even at rest. You see, even at rest, 4, even at rest he is having discomfort. So this is severely compromised. So what are the 4 grades of NYHA classification of heart disease? Can you say? Say 1. Uncompromised. Uncompromised. Grade 1 is uncompromised. Say grade 2.
Grade 2.
Slightly compromised. Compromised. And grade 3. Markedly compromised. Compromised, yes. And grade 4 is severely compromised. Okay, so we looked at USMS, that's the mnemonic. USMS, uncompromised, slightly compromised, markedly compromised, severely compromised. This one is at rest. Markedly is less than ordinary activity, slightly is ordinary activity, causes discomfort. Uncompromised is obviously uncompromised, no problem. See, this grading is based on symptoms, nothing to do with the anatomical type of heart disease or the pathology. Okay, so the same thing here in the table. If you want, you can see this. So what are the symptoms that there will be there? Palpitations, breathlessness, fatigue, syncopes also can be there, right? That is fainting episodes. Okay, so this is the NYHA classification of heart disease. So now let us move on to the heart disease in pregnancy. So we have come to the obstetric topic, heart disease in pregnancy. So basically here you have 3 groups, not grades. What do you have here? Groups. So you have group 1, group 2 and group 3. Group 1, group 2, group 3. And group 1 is minimal risk, 2 is moderate and 3 is major risk. Guys, focus here. What are we looking at? We are looking at the heart disease in pregnancy. There are 3 groups. Okay. In that you are using the same NYHA classification. So here you can see minimal risk. Okay, let's take minimal risk first. Minimal risk are some heart disease like ASD, VSD, patent ductus arteriosus, Fallott's tetralogy which is corrected, mitral stenosis which is grade 1, grade 2, that is uncompromised or slightly compromised kind of a thing. Bioprosthetic valve, that means if they have a bioprosthetic valve, because artificial valve is coming here. Can you see? Artificial valve is here. So bioprosthetic is still fine. If they have bioprosthetic valve, it is minimal risk. Okay. So what are the minimal risk? ASD, VSD, PDA, Fallott's tetralogy which is corrected, mitral stenosis which is grade 1, grade 2 and bioprosthetic valve. These are minimal risk in pregnancy. Got it, guys? So what do you mean by Fallott's tetralogy? The same overriding of aorta, VSD, what am I saying? Pulmonary stenosis, right ventricular hypertrophy. So do you remember this? Fallott's tetralogy, 4 things. VSD, overriding of aorta, pulmonary stenosis, right ventricular hypertrophy. If this is corrected, then it is a minimal risk, okay, in pregnancy. Now coming to moderate risk in pregnancy, it can be the same Fallott's tetralogy which is uncorrected. Let's take a better color. Fallet's tetralogy, which is uncorrected. Mitral stenosis, this time, which is NYHA grade 3, grade 4. Grade 3, grade 4. Focus here. Grade 3, grade 4 of NYHA comes under group 2 of classification of heart disease in pregnancy. Okay. So this is something that you have to understand why you need NYHA classification, right? So here also mitral stenosis. Here you have here also tetralogy of Fallet. You have Fallet's tetralogy. FT is it? I thought it's TOF. So mitral stenosis and tetralogy of Fallet you have in both group 1 and group 2, right? But in the first one, you understood that it is grade 1, grade 2. Okay. And in this one, it is grade 3, grade 4. NYHA. This is group and that was grade. Just focus here. And tetralogy of Fallet, if it's corrected, it is minimal risk. If it is uncorrected, it is moderate risk. What are the other things? If this mitral stenosis is involved with atrial fibrillation, if there then also it is a moderate risk. Mitral stenosis with atrial fibrillation. Guys, focus. What are we looking at? We are looking at group 2. Can you say group 2?
Group 2.
Very good. Group 2. So in that you have mitral stenosis, NYHA grade 3, grade 4 and mitral stenosis with atrial fibrillation. We have Marfan syndrome. We have aortic stenosis. We have artificial valve. Most of the things here seem to be AAA. Aortic stenosis, atrial fibrillation, artificial valve. Okay. And Marfan syndrome. Okay. And again here, guys, focus here. Come on, look at this. Marfan syndrome is here with normal aorta. Marfan syndrome with aortic involvement becomes a major one. Can you see? Here you have Marfan syndrome. We won't write MS because MS will look like mitral stenosis. So let's write Marfan syndrome. Marfan syndrome. So in the group 2, Marfan syndrome is normal aorta, and in Marfan syndrome with aortic involvement, it becomes major risk. Okay. So what is Marfan syndrome, guys? Marfan syndrome is a connective tissue disorder. Where are we? Here. So basically, now we are moving on to group 3. Group 3 is major risk in pregnancy. See, this is not just increasing the morbidity, it is actually increasing the mortality of the mother. That is why this topic is very important, heart disease, okay, in pregnancy. So look at the major risk. Pulmonary hypertension, Marfan syndrome with aortic involvement, aortic coarctation with valvular involvement. So just look at this. We'll draw a nice heart to explain. So what are the high risk things? Pulmonary hypertension. So drawing the lungs here. So pulmonary hypertension is a major risk. Marfan syndrome in which the aorta is involved is a major risk, and aortic coarctation, that is narrowing, which is also involving some valves, valvular involvement. Coarctation of aorta with valvular involvement will become major risk. What are the 3 major risks? Can you repeat? Say pulmonary, hypertension. Very good. Then say pulmonary hypertension. Then Marfan syndrome. Can you say Marfan? Marfan syndrome. Marfan syndrome with involvement of, can you say aorta? Can you say coarctation of aorta with valvular involvement. Thank you. So those are the 3 major risks. Pulmonary hypertension, Marfan syndrome with aortic involvement, aortic coarctation with valvular involvement. Okay. So did you understand the groups in heart disease in pregnancy? Okay, guys. So basically this mitral stenosis mostly is caused by rheumatic heart disease, which is the most common cardiac condition looks like. Okay. Now, let us, where are we? Here. So these people, what symptoms will they have? We already told you that the symptoms can be breathlessness, nocturnal cough, dyspnea, chest pain, right? So these are standard things that you have learned in medicine also, the symptoms of heart disease. Breathlessness, syncope, cough, nocturnal cough. Nocturnal cough, in the night the cough is more, right? Nocturnal cough, chest pain. Okay, chest pain most people will say. surely. The other three things you should know. Okay. Termination with, so in these people, if they have some serious heart conditions, they can be suggested a termination of the pregnancy within 12 weeks because the maternal mortality is more, isn't it? So within 12 weeks, they can be suggested a termination of pregnancy when, if they have had, if they are having primary pulmonary hypertension, Eisenmenger syndrome. What is this Eisenmenger syndrome? So basically, Eisenmenger syndrome is where there is a long-standing left to right cardiac shunt which is caused by a congenital heart defect. Okay, so what is that? Long-standing left to right shunt is there. So can you imagine if this is the heart, there is a left to right shunt. So what will happen if there is a left to right shunt? This is kind of okay, right? This will be acyanotic according to me. So the oxygenated blood can come to the right side. But in these people, eventually the shunt can become cyanotic right to left. Okay, so anyways, this is an indication for termination within 12 weeks. Then there can be a pulmonary veno-occlusive disease. Okay, can we read this as pulmonary vein occlusive disease? So basically, pulmonary vein will carry what? Oxygenated blood, isn't it? Back to the heart. So there could be a pulmonary veno-occlusive disease, severe aortic stenosis. Whenever there is aorta involvement, they seem to be taking more stress, right? Can you feel that? Whenever there is aortic involvement, there is major risks that they told you, right? Group 3. So look here. See? Aortic involvement. Whenever there is aortic involvement, they seem to be taking it as a major risk, okay? So here we have seen termination can be offered to these people. Then they can be on anticoagulant therapy. Some anticoagulant therapy can be given like warfarin, low molecular weight, heparin, etc. depending on the specific conditions, guys. Cardiac failure can happen in these people at 30 weeks of pregnancy, around that. During labor, they can have a cardiac failure, or soon after delivery, they can have a cardiac failure. Please pay attention here. We're going in kind of an order here. These are the symptoms. Offer a termination, still it goes, try to manage with anticoagulants. These people can go into cardiac failure. They can go into preterm labor. There can be IUGR in case it's a cyanotic heart disease. If the mother has a cyanotic heart disease, so we'll use a blue. If she has a cyanotic heart disease, and then what will happen to the baby? The baby can have IUGR. We'll draw some sad smiley there. Okay, not possible to draw. So basically, IUGR can happen in cyanotic heart disease. Okay, then coming to induction. See, induction of labor can be done in select cases because induction of labor, not all heart disease you will do. Select cases they can do induction of labor, but you have to be very careful that you will not do fluid overload. You should not give her extra fluids. What will happen if you give her extra fluids, guys? Oh, volume overload. Yes, the heart will have to pump all that fluid, isn't it? So basically, in these people, you will have to adopt a lateral recumbent position to reduce the compression on the aortocaval system. How will that lateral recumbent position look? So now let's move on, guys. We are here. Focus, guys. We are looking at induction. So basically, you will have to give her oxygen, analgesia, antibiotics, etc. may be required. You will have to closely monitor these people, guys. You'll have to look out for the pulse, the respiratory rate, how's the cardiac activity, central venous pressure, etc. You'll have to monitor. Guys, what are we talking about? During labor, you will give her oxygen if required, analgesia, antibiotics, etc. You will closely monitor her pulse, her respiratory activity, cardiac activity. I'm thinking blood pressure, SpO2, etc. Central venous pressure. You're checking the venous pressure, central venous pressure. Okay. Because I'm thinking if a uterus contracts and the blood returns more to the systemic circulation, there can be more venous pressure, is it? See, these people should not strain themselves, so that's why they can give them forceps or vacuum delivery, okay? To avoid strain or to reduce the second stage of labor. So, instrumental delivery can be more in these people. Do not give IV ergometrin. So, what happens with this? There will be sudden, contractions of the uterus, and there will be venous return to the heart will increase, and there will be overload of the heart, okay? So, what will you not give? You will not give ergometrin. Say ergometrin.
Ergometrin.
Yeah, you should not give, okay? Guys, then look at this. So what will you give if there is PPH, etc.? What will you give then? If you cannot give ergometric, you can give oxytocin and furosemide. Why? To reduce the overload on the heart, right? Good. So did you understand this, guys? This is management of heart disease and pregnancy. We have come till the induction and how we will progress. Next, we'll move to severe heart disease. What you will do? You have to do C-section. C-section is indicated for these heart diseases. If she has had a recent myocardial infarction, congestive heart failure, is it? Coarctation of aorta, we already told you, is a major risk, especially with the valvular involvement, right? Aortic dissection or aneurysm. What do you mean by dissection? This is more like there can be tears in the aorta, okay, in the inner layer of the aorta. So that is what dissection means, okay, tears in inner layer of aorta, okay, or if there's aneurysm and all, these are indications for C-section, okay. Aortopathy with aortic root greater than 4 centimeter. What do you mean by aortic root? Root is, I think, the part that comes out from the left ventricle. That's what it sounds like. Yes, so look at this. This is the ventricle, let's say. Here you have the ventricle, here you have the aorta. So here between the ventricle and the aorta, you have the aortic root. See? This is the aortic valve. This little too much of scientific information here. Let's look at this. So this is aneurysm, this one, which is ruptured aneurysm. Here they are showing. Here they are showing you aortic root. So if there is aortopathy with aortic root greater than 4 centimeter, if greater than 4 centimeter is involved, is it, in the aortopathy? Okay guys, and now look at the last indication here for the C-section. If she has been on warfarin treatment in the last, within 2 weeks. Warfarin is an oral anticoagulant, isn't it? So what will happen in these people if they go into normal labor? They are preferring a C-section. So they don't prefer normal labor, vaginal delivery in these people. With warfarin treatment, they are putting it as an indication for C-section. So did you understand, guys? So where are we? Just do you know what we are looking at? We're looking at heart disease and pregnancy. So basically we saw the management. We have come till here, induction, and then we have spoken about cesarean indications, and then coming to puerperium. So basically you have to observe these people for a longer time, right? Because you know there can be sudden death when and all, 30 weeks, labor, soon after delivery, etc. Contraception, now you observe them, then finally contraception. So basically in these people you don't want to give hormones, etc. So they are suggesting barrier method of contraception, progestin only pills or vasectomy for the male partner, because it is better way of contraception for heart disease and pregnancy. So now let's go to delayed complications, guys. Basically, delayed complications can be arrhythmias, cardiac rupture, infective endocarditis that will anyways lead to thromboembolic phenomena, mitral valve prolapse. Okay. So what are the, so we have gone step by step. So puerperium over, then you're giving contraception. What is delayed complications? Arrhythmia, cardiac rupture, infective endocarditis. Obviously, whenever somebody has some problem with the heart, then some bacteria will go and sit there. It will become infective endocarditis. This will have vegetations. Those vegetation can get dislodged and cause thromboembolic phenomena, etc. These people can have mitral valve prolapse. So it will start off with all the mitral valve problems, and then it is going into prolapse. Okay. Now, if there is a cardiac failure during pregnancy, how will you manage? Look at this one also. The principles are same as a non-pregnant woman. A cardiologist should be there. Underlying pathophysiology, everything, the causes you should understand, and based on that you will treat. Okay. You will put her in proper position, I'm guessing, because you want less venous return to the heart, right? You won't make her sleep. Sleeping will increase the venous return to the heart. You will give her oxygen. You will monitor her with ECG, pulse oximetry. You will give her a diuretic, so it will reduce the load on the heart. You will give furosemide, right? Then you can give mechanical ventilation. That's what is written here. Oxygen, you will not just give oxygen, you will give mechanical ventilation with that. Morphine to reduce pain, we know, but does morphine do anything to the heart also, guys? Cardiac output, heart rate, just check that, okay? Then coming to digoxin, what does digoxin do to the heart? Do you know what is the action of digoxin on the heart? Basically, it can make the heart strengthen. It can strengthen the force of the heart, etc. So it can make the heart strong. How? Look at this. It's a cardiac glycoside, digitalis. It will bind and inhibit the sodium-potassium ATPase. There is increased calcium uptake. So if there's increased calcium uptake, what will happen? So there is increased availability of calcium for excitation, contraction, coupling. So there will be increased myocardial contractility. So there will be an increased cardiac output. But this one can cross the placenta and it can be excreted in breast milk. Okay. So now coming to dysarrhythmias. If there are dysarrhythmias, you will treat it with quinidine or electrocardioversion. If there are tachyarrhythmias, gives adenosine. Okay. Or DC version. Basically that is to make sure that the normal heart rhythm is achieved, isn't it? So basically you will do all that for cardiac failure in pregnancy, very similar to a normal cardiac patient. Okay. So in this video, what and all did you look at? You looked at NYHA classification of heart disease, uncompromised, slightly compromised, markedly compromised and severely compromised. And based on that you have groups of maternal heart disease because it increases maternal mortality. You should know about this. Group 1 is minimal risk like ASD, VSD, PDA, Fallout cytology which is corrected, mitral stenosis under grade 1 and grade 2 of NYHA, that is uncompromised and slightly compromised. And if they have a bioprosthetic valve, minimal risk. Moderate risk will be mitral stenosis which is grade 3 and grade 4 of NYHA, aortic stenosis, Marfan's syndrome with normal aorta, Marfan syndrome with normal aorta, Fallout cytology which is uncorrected. Here you got corrected, here you are getting uncorrected. Mitral stenosis with atrial fibrillation, artificial valve. Remember here Marfan syndrome with normal aorta. When you come to group 3, it is Marfan syndrome with aortic involvement that becomes major risk. Even pulmonary hypertension, aortic coarctation with valvular involvement becomes a major risk. Okay. So pulmonary hypertension, Marfan syndrome with aortic involvement, aortic coarctation with valvular involvement are group 3 major risk. Okay. So basically in our country, rheumatic heart disease is common and it will lead to mitral stenosis. Mitral stenosis can be a group 1 or a group 2 based on the symptoms. So you can see here the mortality rate 0 to 1%, 5 to 15, 25 to 50%. So group 3 has 50%, 25 to 50% mortality. It's not morbidity, it's mortality itself. Okay, so that's why it's very important to manage it correctly, right? You should know the symptoms. You should know if you can offer termination for certain conditions like pulmonary hypertension, Elsen-Menger syndrome, pulmonary veno-occlusive disease, severe aortic stenosis. In those people, you can suggest a MTP. You can ask these people to take some anticoagulants. Cardiac failure can occur in these people. Preterm labor can occur. IUGR in cyanotic heart disease can occur. You can induce labor in certain people, not all. Certain heart disease you can. You should take care about fluid overload, lateral recumbent position, give oxygen, analgesia, antibiotics as required. Monitor very carefully. To reduce the strain, you can do a forceps or vacuum delivery. You should not give ergometrin. You can give oxytocin and furosemide to control the PPH. For severe heart diseases, C-section may be suggested. The indications are recent MI, congestive heart failure, coarctation of aorta, aortic dissection, aneurysm, aortopathy with aortic root greater than 4 cm. A warfarin treatment within 2 weeks is an indication for cesarean. Heart disease and pregnancy, okay. Continuing puerperium, you'll observe for 24 hours. Discharge only after a few days looks like. Contraception should be barrier method or vasectomy for the male partner. Delayed complications can be arrhythmias, cardiac rupture, infective endocarditis, thromboembolic phenomena, mitral valve prolapse. If there is a cardiac failure, how will you manage? It is very similar to any other cardiac state. You should have a cardiologist and then you should put the person in proper position. Oxygen should be given. Then you can give ECG, pulse oximetry. You have to monitor. Furosemide you will give to reduce the volume overload. Mechanical ventilation, morphine, digoxin, quinidine, adenosine. Okay. So this is the management of cardiac disease in pregnancy. Okay, that's it for now, guys. Bye bye.